Hello everyone. Today we're going to continue our study of the vertebral column, and in particular today we're going to be covering the positioning of the lumbar spine, the sacrum, and the coccyx. Let's start out with the lumbar spine. In the lumbar spine, we've got our essential projections being the AP, the lateral, a lateral of L5s1, which is generally called the spot, AP obliques, RPO, and LPO, and the AP axial lumbosacral junction at SI joints, which is called the Ferguson Method. For an AP of the lumbar spine, I'd like you to make sure that as I'm speaking that you're referencing the textbook, looking at the pictures, but for your Apl spine, you have the patient either supine or upright. The MSP is centered to the midline of the grid. You've got the shoulders and the hips in the same horizontal plane. The arms are crossed on the chest to make sure that they're out of the field of interest. And if you are doing a supine, you're going to reduce the lordosis by flexing the hips and knees to place the lower back then closer to the table. Your central ray is going to be perpendicular to the IR. For lumbosacral exams, that's entering at the iliac crest, which is at L4. For lumbar only, you would enter a little bit higher, 1.5 inches above the iliac crest, which is at L3. So it would be generally whatever the institution that you're at. Are they doing the images just for the lumbar area, or is it for the lumbosacral area? Your collimated field is 8 by 17 or 14 by 17 inches if you're going to include the entire abdomen. Very, very important. You're going to be asked on the registry which views demonstrate the intervertebral foramina and which views demonstrate the Zyg Apophyseal joints. And that's going to be for each part of the spine. You want to remember that the lateral of the lumbar spine demonstrates the intervertebral foramina. These are these black holes that you can see through which the vertebral spinal nerves will exit. So the lateral demonstrates the intervertebral foramina. For a lateral, it can be done recumbent or upright. Part positioning, true lateral with your MCP vertical. The knees are flexed, they're superimposed. Excuse me, the arms with the elbows flexed are at right angles to the body. And you're going to have a radiolucent support under the lower spine to make sure that it's horizontal if needed. Central ray is perpendicular to the IR. It enters the patient at the MCP L4, which is the iliac crest. If the spine is not horizontal, if you did not put a sponge, you're going to have to angle caudally 5 to 8 degrees, more so for females because of the broader hips. Your collimated field remains at 8 by 17, and oftentimes you're going to see the tech put a lead strip behind the patient. This is going to help reduce scatter, which would be reaching the detector and perhaps prematurely cutting off the exposure. So that remember that as the part size increases, you generate more scatter, and if you can get rid of that, that would be great. So how do you do that? You put this lead strip behind the patient. For the L5s1 Lateral, which is the spot, your patient position is in a lateral recumbent. MCP is perpendicular to the IR. Your hips are extended. Superimposed knees could be slightly flexed. Elbows are flexed. Arms are at right angle to the body. And you're going to support the lower spine in a horizontal position in the same manner as for the lateral. As far as the central ray goes, when the spine is horizontal, okay, you're going to just use a perpendicular beam. It would be entering at a point on the coronal plane 2 inches posterior to the anterior superior iliac spine, and then 1.5 inches inferior to the iliac spine. So let's think about this. So 2 inches posterior to ASIS. So you're going to palpate the ASIS. You're going to go 2 inches posteriorly. And from that point, then, you're going to go 1.5 inches inferior to the iliac crest. If the spine isn't horizontal, you're going to angle 5 degrees for males, 8 degrees caudal for females. So that's very important to remember. You often see questions about this on exams, review books, on the registry. 5-degree caudal for males, 8-degree caudal for females. You're going to use a collimated field, only about 6 by 8 inches. We call this the spot image. So just looking at that that vertebral space between L5 and S1. If we move on to the obliques, obliques of the lumbar spine are done to demonstrate what is called the Zyg Apophyseal Joints. Now remember from the anatomy section, your Zyg Apophyseal joints are going to be those small joints between the inferior articular process of the vertebrae above and the superior vertebral process of the vertebra below. So between, basically, if we're looking at an oblique, the vertebra looks somewhat like a Scotty dog. So we've got the foot of the Scotty dog above, which is the inferior articular process. And then we've got the ear of the Scotty dog below, which is the superior articular process. That little space between the foot and the ear is the Zyg Apophyseal joints. Both sides are going to be examined for comparison. So we're going to do the RPO and we're going to do the LPO. For the obliques, recumbent or upright, part positioning, 45-degree posterior oblique position. If they're lying down, radiolucent support under the elevated side. So lumbar spine obliques are done with a 45-degree rotation. Central ray is perpendicular. Now, where to put the central ray? A little bit tricky. You're going to enter the patient 2 inches medial to the elevated ASIS. So you're going to palpate ASIS. They are turned on their side, so you're going to be working with the ASIS that's on the upside, the elevated side, and you're going to go 2 inches medial at L3, which is 1.5 inches above the iliac crest. Collimated field, 9 by 14 inches. For the Ferguson method, the Ferguson method is going to be a supine position to open up the interspace between L5 and S1 in an AP presentation. So the MSP is centered to the IR. You're going to extend the lower limbs or abduct the thighs and place them vertical. Central ray is 30 to 35 degrees cephalad. Once again, please reference your book as we go through these. There's some great photos in Merrill's. You're going to use less of an angle for males, more for females. Ferguson originally recommended 45-degree angle, but now we do 30 to 35. And where you're going to enter the patient, it's going to be along the MSP at 1.5 inches above the pubic symphysis. So just to make things clear, your L5s1 spot is used to open up the joint in a lateral presentation. The Ferguson method is used to open up the L5s1 joint space in an AP presentation. You're going to use a collimated field, 8 by 10 inches or 10 by 12. As a note here, may also be performed with patient in a prone position, which would be a PA axial. but in this case then you'd have to change the direction of your angle 35 degrees caught at. It says only AP axial is recommended as the Ferguson method. For SI joints, we're going to do RPO, we're going to do LPO. Very, very important to remember when you're doing SI joints. The SI joint farther from the IR is demonstrated. Now, what we mean by demonstrated is that it's open. So if I'm going to be doing the RPO, the left SI joint would be open. If I'm doing the LPO, the right would be open. So farther from the IR. Patient position is supine. We use a 25 to 30 degree posterior oblique position. Body is supported in position, long axis parallel with table, and IR is at the level of the ASIS. Central ray perpendicular, entering 1 inch medial to elevated ASIS. So you palpate the ASIS and go over 1 inch medially. Collimated field, smaller field, 6 by 10 inches or 6 by 12 inches. For the sacrum and coccyx, sacrum, AP axial and a lateral, coccyx, AP axial and a lateral. For the sacrum and coccyx, most of the time you're going to have the patient at least void before taking these x-rays. However, it is suggested in marrows that the bowel should be prepped as well, which means that before taking the images, you should ask the patient if they could evacuate anything from their bowels. And the reason for this is that feces in this area is really going to obstruct the presentation of the sacrum and the coccyx. For the AP axial of the sacrum, patient is supine, may also be performed with patient prone if needed for comfort, because sometimes it's difficult if you have a fractured sacrum to be laying on it. MSP, midline of table, ASIS, equidistant from table, so they're not rotated at all. Arms are in a comfortable, symmetric position out of the field, and the knees are supported if the patient is supine. Central ray. For the sacrum, you're going to angle up, so 15 degrees cephalad. If they're prone, however, if you flip them over, of course, then you're going to have to angle in the opposite direction. But for the AP axial, you're going to angle in a cephalad direction. You're trying to take that curved bone and kind of flatten it out of the image. It enters the MSP 2 inches superior to the pubic symphysis. For prone, enters MSP at level of sacral curve. And there's a collimated field about 10 by 12 inches. AP and PA axial coccyx. Patient is supine or prone. Once again, you're choosing the position that's maximizing patient comfort. Part position same as used for the sacrum. For the coccyx, because when you're laying AP, that coccyx kind of tips up, you need to hit it with a 10-degree caudal angle, and that's going to flatten it out on the image. So for the sacrum, you're angling cephalad. For the coccyx, you're angling caudal. And the degree is very important, 10 degrees caudal. Of course, if you were PA, it would be 10 degrees cephalad. You're going to enter the MSP 2 inches superior to the pubic symphysis. For the PA, you'd go MSP at the coccyx, and you're going to use about an 8 by 10 inch field. For the lateral of the sacrum, recumbent lateral, hips and knees are flexed for comfort. Arms are at right angle to body, knees superimposed, support spine to the horizontal position. The interiliac plane, so that plane between the ilia perpendicular to IR, shoulders and pelvis in true lateral, MCP is vertical, and the sacrum is centered to the IR. Central ray is to the level of the ASIS to a point 3.5 inches posterior. So 3.5 inches posterior for sacrum, 10 by 12 inch collimated field. For the lateral coccyx, patient and part positions are the same as used for the sacrum itself. Central ray. So you're going to go perpendicular 3.5 inches from the ASIS, and then you're going to go 2 inches inferior. So from the ASIS, you go 3.5 inches back, and then 2 inches down, so 2.5 inches inferior to ASIS. Collimated field 6 by 8 inches. Close collimation improves visibility. You're getting rid of a lot of that scatter, and there is a lot of scatter, so that lead rubber behind the patient is going to be used to help absorb even more of the scatter before it reaches the detector. Your book talks about the scoliosis series. Typical scoliosis examination may include a PA upright, PA upright with lateral bending, lateral upright with or without bending, and then a PA recumbent. Notice it can also be done AP. Many places will do it PA because that helps to absorb radiation before hitting the gonadal region. What does the scoliosis series do? It demonstrates the amount and degree of curvature that occurs with force of gravity acting on the body. It's also used to evaluate any fixation devices such as Harrington rods, which are used to help correct severe scoliosis. And then bending studies could be used to differentiate between primary and the compensatory curves. Remember, your compensatory curve develops to keep the head over the body. Long IRs are used. 60-inch SID demonstrates the entire spine with one exposure. Today with digital, oftentimes we use stitching to bring the images together. There are some special radiation protection requirements that are listed in your book. This would include protecting the gonadal region and also the breast tissue for the female. For the series itself, for the PA Thoracolumbar Region, patient is upright. They face the vertical bucky. Ensure the MCP is parallel to the bucky. Abduct the arms so they're not in the field, and your central ray is perpendicular. For the lateral thoracolumbar, a patient's upright, body is lateral, MCP is perpendicular to the bucky, arms are at right angle to the body, and the central ray is perpendicular to the bucky. For the PA thoracolumbar, the Ferguson method for scoliosis, first radiograph taken in same manner as previously described. Second PA radiograph taken with patient's convex side elevated 3 to 4 inches. Ferguson specified the elevation must be sufficient to require a patient to expend effort to maintain the position. For your Apl spine, you want to make sure that on the image itself there was proper collimation. Area from the lower thoracic vertebrae to the sacrum is demonstrated. The X-ray beam is collimated to the lateral margin of the psoas muscle, and there isn't any artifacts across the mid-abdomen from any elastic in the patient's underclothing. It's going to depend on the site that you're at. At some sites, some places have the patients remove their underwear. Of course, they have a hospital gown on. Other places, they have them leave the underwear on. So it's really up to the site that you're at. There shouldn't be any rotation since it is an AP. You're going to have symmetric vertebrae. The spinous processes will be centered to the bodies. So basically what it looks like in an AP is you see the vertebrae, and then it's almost like you see these little teardrop structures coming down, and those teardrop structures are the spinous processes. They should be centered to the bodies. Sacroiliac joints are equidistant from the vertebral column. Open intervertebral disc spaces are demonstrated, and soft tissue and bony trabecular detail. Here's a good AP. You can see you've got the SI joints included. You have all 5 vertebrae on the image, all 5 lumbar vertebrae. Now remember how you're going to know. You're going to look to see if you can find T12, which of course has the rib on it, and then right underneath that would be L1. You're going to count out 5 lumbar vertebrae. Some patients do have 6. It's a fairly common anomaly, so you want to make sure that you have all of the lumbar vertebrae on there. For the lateral of the lumbar spine, proper collimation, area from lower thoracic vertebrae to coccyx, area from lower thoracic vertebrae to proximal sacrum using an 11 by 14. Vertebrae are lying down the middle of the image. There isn't any rotation. Superimpose posterior margins of each vertebral body. So it's almost like if you took a block and if you turned it, both sides of the back of the block, which would represent like the body, should be superimposed. Nearly superimposed crest of the ilia when the X-ray beam is not angled. Spinous processes are in profile. You see on the lateral, remember, open intervertebral disc spaces and intervertebral foramina. So intervertebral foramina are demonstrated on the lateral. And then you see soft tissue and trabecular detail. Here's a good lateral. You've got all of the lumbar vertebrae on there. There isn't any rotation. I'm looking at the posterior aspect excuse me, of the vertebrae, and I notice they're all superimposed. And those black holes that I can see, which are posterior to the vertebrae there, those are the intervertebral foramina. For the L5s1 spot, evidence of proper collimation, lumbosacral joint and center of exposure area, open lumbosacral intervertebral disc spaces. The crest of the ilia are closely superimposing each other, and then soft tissue and bony trabecular detail. Here's an excellent L5s1. You can see that nice open joint space between the 5th lumbar vertebra and the 1st sacral segment. AP oblique lumbar spine. Evidence of proper collimation, area from lower thoracic vertebra to the sacrum. This is very, very important. Zyg Apophyseal joints closest to the IR. It should be open and uniformly visible through the vertebral column. So when you are doing AP obliques of the lumbar spine, the RPO would demonstrate the Zyg Apophyseal joints on the right side. The LPO would demonstrate the Zyg Apophyseal joints on the left side. So those that are closest to the IR. Now, of course, if you were doing the PA obliques, this would be reversed. But most places do the AP oblique, so Zyg Apophyseal joints closest to IR. Now, sometimes you don't see the joint very well. And if that's the case, you're going to look to the eye of the Scotty dog, which is the pedicle. When the joint is not well seen and the pedicle is anterior on the vertebral body. So you look at the body, which is that kind of rectangle square, and if you notice that the pedicle, which should be right in the middle, is a little bit anterior, the patient wasn't rotated enough. So you can go back and correct that error. When the joint isn't seen well and the pedicle is posterior on the vertebral body, that tells you then the patient was rotated too much. Remember, you're trying to get the eye of the Scotty dog right in the middle of the vertebral body. Please, once again, reference your book for the images. Vertebral column is parallel with the tabletop, so T12 to L1 and L1 and 2 intervertebral joint spaces remain open, and you're seeing soft tissue and bony trabecular detail. Here is a beautiful AP oblique of the lumbar spine. What you are looking for are these little spaces between the foot of the Scotty dog above and the ear of the Scotty dog below. So when you look between the foot and the ear, you see these little tiny black, almost slit-like spaces. Those are the Zyg Apophyseal joints, and that's what you want to see on a good oblique. Also look at the eye of the Scotty dog as it relates to the vertebral body. The eye of the Scotty dog should be right in the middle of that vertebral body. Let's move on to the Ferguson Method, AP Axial Lumbar Sacral Junction and SI joints, evidence of proper collimation, lumbosacral junction and sacrum, open intervertebral disc spaces between L5 and S1. Both sacroiliac joints are adequately penetrated, and you should see soft tissue and bony trabecular detail. Here is a good AP Axial Ferguson method. Now remember, the AP Axial Ferguson method opens up the joint space between L5 and S1. If you look here at L5, look at S1, and notice that black space between, that's the open joint space. For SI joints, evidence of proper collimation, open sacroiliac joint space with minimal overlapping of the ilium and sacrum, joint decentered on the radiograph, and soft tissue and bony trabecular detail are seen. It's not going to be this beautiful black space that you're going to see as you do in most joint spaces, because if you look at the sacrum and then you look at its auricular surface, look at the auricular surface of the ilium, they're both roughened up areas, so you're not going to get this beautiful, nice joint space. But the arrow is pointing to the area of the SI joint. You should see evidence of proper collimation, soft tissue and bony trabecular detail, sacrum is centered and seen in its entirety. Sacrum is free of foreshortening with the sacral curvature straightened. Pubic bones aren't overlapping the sacrum, and there should not be any rotation of the sacrum as demonstrated by symmetric ala. So here's a beautiful AP axial of the sacrum. Notice the tip of the coccyx is going to be superimposed on this one usually by the pubic symphysis area, but it does give you that 15-degree cephalad angle, gives you this beautiful image of the sacrum flattened out on the image itself. PAAP coccyx, evidence of proper collimation, soft tissue and bony trabecular detail. Coccyx is centered and seen in its entirety. Coccygeal segments are not superimposed by the pubic bones, and there should be no rotation of the coccyx as demonstrated by distal segment in line with the pubic symphysis. For the AP of the coccyx, now we've angled 10 degrees in a caudal angulation, and what we're seeing here is the coccyx now not superimposed by the pubic symphysis. For the lateral sacrum and coccyx, evidence of proper collimation, lead rubber absorber behind the sacrum. Sacrum and coccyx both are demonstrated. Closely superimposed posterior margins of the ischia and ilia are demonstrating no rotation, and you should see soft tissue and bony trabecular detail. Here we've got two images. Here a lateral sacrum on the left and the coccyx on the right. You can see these bones are very, very small. They're very thin. So you need to make sure that you can absorb as much scatter as you can to make the image more contrasting. For the scoliosis series, proper collimation, thoracic and lumbar vertebrae include about 1 inch of iliac crest, vertebral column aligned down the center of the radiograph. Correct identification marker is used, and soft tissue and bony trabecular detail are seen. You can see the curvature here of the spine with this patient that has scoliosis.